to Thank you. Yes, our meeting is going to be recorded, as we earlier mentioned. So our complete health link will be put in the chat. And please check us out. Please download our app. Please engage with us. We also have our navihealth.ai, which is a digital navigation system. And that with navihealth.ai, you can get facilities around you. Is a digital navigation system for you to use. Please, the link will also be put in the chat. Please check us out. Please let us know your thoughts. Let us know your interaction with Navi Health, with Complete Health. And again, our No Job model. Our No Job is a community-based health for in-person support located across different locations in Nigeria and in Lagos. And last but not least, we have the MDOC Quality Network, which sponsors this session currently, and it is capacity building for healthcare workers and providers. Like I said, our Complete Health platform. Please, the Complete Health link is in the chat box. Please check us out. Please download the app on your smartphones. We really appreciate it. Also, navihealth.ai, a digital patient navigation platform with a feedback mechanism. It is also a directory for public and private healthcare facilities, services, and providers. And healthcare workers can sign up on navihealth.ai. Please, you can check navihealth.ai. Is your facility not on navihealth.ai? Please let us know and we'll be able to speak to you. The link will be in the chat. So we'll just take a quick video. All right, thank you very much. Please note that we offer continuous professional development for the doctors, and terms and conditions apply, and only participants with significant attendance during the session will be eligible. Please, to apply, email mqn@mymdoc.com.
Good afternoon, everyone. My name is Aima Uwagboy, and it is my pleasure and my honor to introduce our speaker for today. He's one of the elders in the profession of obstetrics and gynecology, and one I look up to in the profession. I'm always delighted to reach out to him. Our speaker today is Dr. Oriose Donald Imosemi. He's a consultant obstetrician and gynecologist with over 3 decades of experience advancing maternal and newborn health in Nigeria. He is a passionate advocate for evidence-based, low-cost, high-impact interventions. He has dedicated his career to strengthening health systems, reducing maternal morbidity and mortality, and improving health outcomes across Lagos State and beyond. He has held key leadership roles, including serving as medical director of Ibejuleki General Hospital and Lagos Island Maternity Hospital, where his commitment to quality care earned multiple Lagos State awards and prestigious Mameye Hero Award for innovation in maternal and newborn survival. Dr. Imosemi formerly led the Lagos State Maternal and Perinatal Death Surveillance and Response, MPDSR, Technical Committee, where he worked and supported the Federal Ministry of Health alongside alongside others in developing national guidelines and policy documents, including the current guidelines on management of postpartum hemorrhage. So it is no wonder that he is our speaker today. It is my pleasure and honor again to hand over the floor to Dr. Orose Donald Imosemi. Over to you, sir, and welcome. Glad to see you again. Dr. Imosemi?
Yeah, thank you so
Awesome.
very much, for the intro. Let me first of all say, let me thank MDoc and the organizers of, this session for having chosen me, to lead in the what will turn out to be an interactive session. I think what is also important is to acknowledge the audience. I have an idea of, the spectrum of the idea. So I'm going to ensure that I communicate, and I'm going to choose my language and ensure, particularly given the fact that, we're talking about something that is very topical, that is very relevant, that is very germane. Let me also remind our, audience that, like I said earlier, and that also explains why this topic was chosen and delivered on this day, that 5th of October, some few days ago, about 4 days ago, was the first World Postpartum Haemorrhage Day. That was deliberately, chosen by the WHO again to galvanize attention and, gain traction and momentum. Let everybody know what is happening, the problem that hemorrhage causes, and the contribution, to maternal mortality. Our women should not die. And if we have a leading cause that despite all effort, despite all introduction, all interventions, continue to take the lives of our pregnant mother, we must begin to look at what we've done, see what we should be doing differently so that we change the narrative. Also very important, very quickly before I move on, is to know that on that same day, in an almost unprecedented manner, the WHO came up with what has now been, what is entitled, a document, all right? And this is coming out from WHO, titled Consolidated Guidelines, okay, on the prevention, diagnosis, and treatment of postpartum hemorrhage. Incidentally, I had sent my slides in before this landmark, guideline came up. But don't worry, I've quickly gone through, and at the appropriate time, I would bring in what is very important. But you see, the importance of that document should be emphasized that prior to now, there have been a lot of ambiguities and confusions, even in terms of what postpartum hemorrhage is, the definition, what we should be doing to prevent, what we should be doing to manage, what constitutes or what. But what has happened over time is that in the last couple of years is that experts have sat down and have looked at evidence, and they've come up with recommendations that should be adopted and utilized universally, including in Nigeria. And of course, some of them are context specific. In other words, what are those that relate to, to the developing countries, low and middle income countries, and all of that. So that at the end of the day, we will have access to information that will help us manage this challenge that continue to constitute a problem. Next slide, please. Next slide. Okay, so by way of background, maternal mortality continues to remain a major public health, problem globally, where our women who, while doing or effecting their God-given, responsibility to reproduce mankind, continue to lose their lives. And what is even more worrisome is that this thing is disproportionately against the low and middle income countries, where over 80% of pregnant women, while doing their God, ordained responsibility, continue to lose their lives. Okay, even in these countries, there's still problem of inequities, because those who are rich are not likely to die. Those who are in urban areas are less likely to die than those who are in the rural areas, and so on and so forth. And yet it's a human rights issue. The woman in Lagos has the same right to live like the woman in Katsina, in my state, and also the woman that is out there. And yet every year, you have about, in Nigeria, about 82,000 women, representing about 28% of the total number of women who die worldwide every year. And in looking at the cost of this huge number of people or women who die globally, postpartum hemorrhage is the leading cause, globally accounting for about 1/5 of every cause of pregnant women dying. 1/5, that is significant. All right, that's why when you look at absolute figures. And what is even more humbling is the fact that a number of these deaths are preventable, again, by doing simple things. And that is what drives me. Low cost, highly impact, highly effective interventions in all climes, in all situations. We know those things, and yet we're still losing women. So this is an opportunity for us to look at this problem that continues in Nigeria, for example. Again, is the leading cause, accounting for between 25 to 30, depending on the institutions and the location and all of that. And yet it shouldn't be happening. It shouldn't be happening. And yet WHO has a goal that by year 2030, looking at one of the key targets, we should reduce the number of women that die. We should reduce the proportion, the rates, to about 70 per, 100,000 live births. You know where we are? We're about 512. Okay, so what that does mean is that if we are to make progress towards achieving this, we must address the leading cause. And I think that is one other reason why NDOC chose, to have this. Again, back to the front burners. And what has happened at the WHO with the latest guideline, we're in the best position to look at what has been, what should be changing, and what holds the best pathway to the future. Next slide, please. Next slide. Okay, next slide. Okay, so we should be looking at the definition of postpartum hemorrhage. We all know what the definition is. The WHO, of course, looks at before the 5th of October. Please note that, bleeding per vagina after delivery gives us the figure of about 500 mils. Okay, but it recognizes that even at lower, volume of blood loss, women are parturient could still be categorized as having, postpartum hemorrhage. In other words, a woman who is anemic and loses about 300 mils and all that, and begins to show what we call physiological changes, blood pressure, pulse, and all of that, will be categorized or classified as having experienced postpartum hemorrhage. But very quickly, WHO, in its latest model, in its latest guideline, has shifted very dramatically. And it now looks at it from the therapeutic angle. In other words, it expects us moving forward. And I'm happy that you have a lot of policymakers here. Otherwise, they will see access it. That right now, gone are those days when we only visually estimated blood losses. And we all know that this is notoriously inaccurate, as we tend to, underestimate. And so when the problem is there, we don't even know. And we're looking at 500 mils and we're estimating. it's come out to say, no, we should be measuring using calibrated drips. Our policymakers with that, Lagos State already has an idea, but it's the way to go. Calibrated drips after a woman has delivered, if you have on the calibration, you've lost about 300 mils plus manifestations of certain physiological changes, blood pressure going down, especially systolic blood pressure, the pulse going up, and then it's also brought in the concept of shock index, all right, when it looks at the ratio between the pulse and systolic blood pressure. Very clear. If you have that, you need to quickly recognize that this is postpartum hemorrhage. Or we can still use the absolute figures, 500 mils, even where some of these physiological changes haven't ensued, okay? But again, how do you assess? So if you're in a position to assess with the calibrated 500 mils, no physiological changes, we should know that it's postpartum hemorrhage. Why is this very important? This is definitely very important. It recognizes the fact that in postpartum hemorrhage, a number of times you may have just 2 hours to salvage the life of this woman. So there's a compelling need to recognize very early. Okay, if you recognize that very early, it means that you can do a lot of things to ensure that within 2 hours, you give the woman the best chance to survive. That doesn't mean that after 2 hours, we don't keep an eye. And of course, I'm going to speak to that in the next slide. Okay, so note that definition. We're going to be using calibrated drips to measure. If you have 300 mils and then you have changes, note that. 500 mils, no changes, that's postpartum hemorrhage. Okay, it removes all the controversies, all the ambivalences from other associations that talk about 1,000 mils and all of that. Let's get it very early and deal with it. And that speaks particularly to the low and middle income countries that continue to be challenged with their weak health system. How big is this problem? I've already said it. It's a big problem. We have about 14 million cases worldwide and about 20 about 28% of all maternal deaths. Okay, so that implies that in every 4 minutes, we have one maternal mortality due to postpartum hemorrhage worldwide. So that tells you there's a problem, okay? And also for every one life, that there's usually about 10 to 15 cases of morbidities. But all of this happen, again, like I said, in the low and middle income countries, okay? So why is that so? It's because of the fact that, despite the fact that we know the causes and we have solutions, we know what to do. Some of the contributory factors, okay, have continued to remain prevalent in the system. Contributing factors that define our health system, that define our women, that define our policies, okay? We're talking about types 1, type 2, type 3 delays. The woman, that is pregnant, she doesn't even recognize the fact that there's a complication. And even when she does recognize the fact that it's a complication, she's unable to take a decision. Okay, she has to wait for the husband, she has to wait for somebody. I mean, that shouldn't be. Now, eventually that decision is made. Okay, she's had to travel through kilometers. That was type 1. And then in some of our areas, you have to travel kilometers. Okay, and in some of these landscapes, you have insecurity, like up north. And in other areas, difficult terrains, they eventually get to the institution, to the health facility, all right, where, again, because of challenges there, they don't have access. Challenges ranging from problems with the workers, with the infrastructure and all of that, okay? And yet, a number of times we have 2 hours. Next slide, please. Next slide, okay? So it speaks to how big the problem is, all right? Now, postpartum hemorrhage is generally classified into 2 from the point of view of, time of occurrence. Primary postpartum, when it does happen within 24 hours, and the secondary after 24 hours. Secondary postpartum hemorrhage, usually they are due to things that we know that we can easily handle, retained products, infection, and all of that. And of course, poor evolution of the uterus. They are not as deadly. In fact, 45% of all the problems, 45 to 50% of mortality is due to postpartum hemorrhage, usually will happen within the first 24 hours, okay? So, next slide, please. Now, having classified postpartum hemorrhage and having also defined it, let me quickly add that the management of postpartum hemorrhage starts from, early recognition. If I start with prevention, and then to prevent, you must have what we call risk factors. And those risk factors speak to the major causes of postpartum hemorrhage. They speak to, things that cause atony, the predisposing factors to atony, the predisposing factors to lower genital tract injury, the predisposing factors to, retained products, placenta issues, okay? And that is tissues, and the predisposing factors to the last T, thrombin, all right? And I've quickly highlighted a number of these factors here. They are there. In our environment, let me just say that atony, again, constitutes or accounts for a minimum of about 70%. Atony means the uterus being very soft after delivery. It accounts for over 70%, all right? And so what that does mean is that all the factors that predispose to atony, we should look out for them, and it should drive us. And some of them are very prevalent in our environment here. We have a high fertility rate, so multiparity is a problem, is very inherent in our system. We love children, but that is no reason why our women should die, okay? We have the highest twinning rate of pregnancy in the whole world. I'm looking at people from Igbora and western part of the country and everywhere, and Nigeria as a whole. Fibroids coexisting with pregnancy, and so on and so forth. All of these and so many other reasons, prolonged labor and all of that, make atony very, very key, all right? And of course, all the other issues. But let me just quickly add, before leaving this issue of, risk factors, that close to about 50 to 60%, some people have quoted figures as that high, of postpartum hemorrhage that happen do not have any of these factors I've highlighted. All of them that even span and encompass, tears, tissues, and thrombin. So what that does mean is that every woman in labor, every parturient in labor must be seen as being at risk. And so we must be prepared. The system must be prepared for them. Okay? So that is what we call readiness. Okay? So because of all of this, like I said, we must be ready. We must prevent. All right? And in preventing, which is very important, we must look at all of these factors to ensure that we provide quality. So in prevention, which is a vital arm of the management, all right, we have made a diagnosis. We've also said these are the risk factors. The risk factors and other things will help us prevent. We have to look at what we should be doing before the woman gets pregnant, when she gets pregnant, when she's in labor, and then, of course, immediately after labor. All right? And that's what this prevention of PPH does, okay? So the woman, next slide, the woman who gets pregnant in the best possible nutritional state, in the best possible, level of hemoglobin, next slide, please, is likely to do better, okay? So now, when the woman eventually does come, next slide, when the woman eventually does come for antenatal, which is very, very critical, and that's one area where we don't do well when we look at the issue of access. When the woman accesses quality care antenatally, that means that we should be looking at things like anemia. What do? We give iron, we do all of those things, give intermittent prevention against malaria, IPT, give all of those things, okay? And so many other things, ensure that we take care of, worms, especially hookworm in areas where they are prevalent. And all that contextually, depending on where they are. If we do all of this antenatally, we ensure that when the woman is getting into labor, okay, of course, she's in the best possible state. When she's in labor, we ensure that, of course, even in labor, she accesses skill better attendants. Skill better attendants, and where you have protocols, doing the right things antenatally, for example, when they are in labor, monitoring them properly, avoiding prolonged labor, ensuring that, again, we do not, give liberally episiotomy, and that speaks to the second course. Only give when it is needed, and all of that. And then more importantly, I want to emphasize this, providing every woman that is in labor and has delivered a baby what we call active management of the third stage of labor. In fact, where you properly effect this as an intervention, it is been found to reduce the incidence of postpartum hemorrhage by as much as 40%. But there are so many things about it. What are the components? The critical component, of course, is using the right oxytocin. WHO, in its latest model, has been very clear about what we should be doing. Oxytocin it is. However, their context, we'll get to that, okay? So you must prevent. Now, even when you do that, it could still happen. And that is what we call detection of postpartum hemorrhage. Of course, like we said, usually we visually estimate. I've talked about the issue of using calibrated data now. So we must objectively detect and respond. It's calibrated drips now. We don't have to wait for the woman to physiologically show it. However, because of the prevalence of anemia and other issues, okay, we must look out for those women who bleed steadily. It may not be very heavy, but because they are anemic, they begin to have changes in their physiological state. So once it's there, it is there. Next slide, please. Next slide, okay? Now, I have this slide that speaks to the classes of hemorrhage. It talks about class 1 to class 4. And what it does essentially is to look at the amount of blood loss and the impact on the physiological state. But from the point of view of prevention, please, our aim is to try to prevent. And when bleeding does happen, we should try to get it at class 1, where the woman at most loses 15%. We don't, What is important is that at this stage, that parturient's vital signs remain stable. Other than the fact that when I mean the vital signs, here it speaks to the issue of the blood pressure, the pulse, and all of that. They are stable, other than the fact that the woman could have, pulmonary hypertension. By the time we're going to class 2, where the woman has lost 20 to 25%, again, particularly in the young women whose physiological state is such that they can compensate properly, compensate without showing, changes in the blood pressure and so on and so forth. So if you rely on just blood pressure alone without monitoring and recording the blood loss, especially within the first 2 hours, which are just the 4th stage of labor, in quotes, as it were, you lose them. Unfortunately for us, a number of times, especially with our unbooked cases, or with cases that have not been observed, monitored very closely, they come in class 3. By the time we see them in class 4, it's a disaster. In other words, by the time a woman comes to you with a pulse rate, postpartum, 120, and then you have a systolic blood pressure that has dropped to about 60, we are in trouble. We don't want that. And with the present concept, we should be aiming to prevent and early detect. Next slide, please. Next slide, please. Okay, so what I've done essentially is to talk about things that we need to do that will make our management of postpartum hemorrhage in terms of the point of treatment, give us better outcomes. One of the reasons why we've continued to do badly is because we'll not be preventing. We'll not be preventing because of those social cultural factors, some of those delays that I've mentioned. And even when they come to us, we don't detect very early. We must detect very early. There must be a paradigm shift. And all of these things are incorporated, But having established that there is, postpartum hemorrhage based on the drape, based on what we've seen, and based on, like I said, detecting very early. For us to do well, to treat well, we must be ready. Ready means that whether it's at the primary healthcare level, secondary healthcare level, and tertiary healthcare level, and even occasionally at home. Some of our women, because of circumstances that are beyond them, conflicts, long distance and all that, find themselves delivering at home. It's our responsibility as policymakers to even ensure that they don't lose their life. While we continue to work to deal with those conflicts, we must come up with smart interventions to ensure that we even take the battle to save their lives so they are home. But let's look at the larger cases that really come to us. So these people have come to us. We've detected that there is postpartum hemorrhage. Like I said, we're getting them very early. Class 1, where they are stable, but we have evidence, objective evidence now that they are bleeding. All right? What do we do? That institution will do well if they are ready. I want to by being ready. By way of policy, there should be a policy anywhere that says that any woman that comes must access care promptly and quickly, regardless of their creed, of their financial status, their color, their religion. Okay, and more importantly, their financial capability. Hemorrhage, 2 hours, he knows no color, he knows no creed, he doesn't know if you have money or not. If you do not access the care that you need, and how do you ensure that you access this care? Is by ensuring that every facility is ready. So in terms of readiness, what do we mean? It means that in recognition of the fact that this problem is almost inevitable, given the prevalence and given the consequences, we must be ready. Our labor ward, our system must be ready. Ready in terms of materials. We must have maybe a cart that has those basic components that will ensure that if one comes in, we are able to, while calling for help, begin to assess and resuscitate. We must have a hemorrhage cart that has basic things that we need. IV normal saline, infusion giving set, oxytocin in a fridge, or if it's not there, if it's not very effective, any other oxytocin, apart from oxytocin, be easily accessible. It must be there. You must be able to access it so that when they come, we did a study at Lagos Island Maternity Hospital where we showed that you could resuscitate and stabilize a woman within 2 to 5 minutes if you were prepared. That woman has a much better chance. There must be a policy that says out-of-pocket expenditure is no longer a problem. In fact, for me, when they come in, let's get what they need so that we are ready. And then we must have people who are motivated, who have been trained, who have undergone drills, they have been retrained, and who know what to do. And then who are not just working, arbitrarily, but who are guided by protocols. I'm proud to say that in Lagos State and many other states, thanks to the effort of Sorghum, we have, protocols that drive or that guide everybody. But do we use them? And that's why when we are monitoring, we must ensure compliance. We must ensure that those who are just coming are drilled and they are guided. And these protocols, of course, derive from guidelines. Now we have a latest guideline from World Health Organization that attempts to uniformize, that removes all the ambiguities that come with various protocols and guidelines from American College of OBGYN, from UK College of and all of that, Royal College, Japan. We don't want all of that. WHO has taken it to all of it. So after this, all policymakers at all levels, federal level, state, PSC level, must access this and begin to revisit what we have in existence so that we have protocols that have been updated, that of course are driven by what? Best practices, best body of evidence, and I remove all veneer of doubts about what we should be doing. So those protocols must be there. Once they are there by motivated workers who are very sensitive, who know that they must show respect, they must show care and sensitivity to the woman who has just delivered. That is it must be ready. And it must be appropriate for every state. So for the PAC, we must have a protocol that is appropriate. Of course, PACs must know, PACs are of course at primary care center, they must draw a line. We must have a very effective referral system for cases where they know. Now, with all of this in place, you have hemorrhage. What should we be doing? For people who are ready, we should call for help. In calling for help, you want, depending again on where you are, the most senior per se, if it's in a PSC, the doctor in charge, the matrons that are there. Again, we are aware that elsewhere, we do not have the luxury of this. But you have people, you have systems. And we do know that in secondary health facility, you even have consultants. So they say, you call for help. The help will cost you in the secondary health facility that are usually reference centers that are also configured to provide what we call comprehensive emergency care services. They call for help. There's a leader. Let the anesthetist know. The midwife is there. You know, occasionally, they may even have to bring in a hematologist. All right? They are ready. Okay? And then, while they are quickly assessing, the rule again still continues to remain ABC. For those cases that we have and that we usually purpose to get very early, they are stable. Okay? But that still doesn't mean, for those other bad cases that come in extremis, you must still do ABC of resuscitation. Ensure that the airway, the breathing and all of that, and the circulation are there. But once as stable as they are, ensure that you can relate them, they are bleeding, you take blood for grouping and cross-matching and all the other blood works. Ensure that you monitor, you have their vital signs, there's somebody documenting. A number of times you should catheterize in a very clean manner, okay? Again, to monitor and ensure that the woman is making urine. All of these begin to give you a picture of the physiological state, okay, of the woman, okay? So you have called for help, all right? So next slide. We've agreed that the problem is there. So what is now being canvassed, okay? What is now being unequivocally, unambiguously canvassed for, apart from detecting, apart from preventing, when you prevent, you early detect. When you early detect, you now do what we call first response, early response, first response of intervention. And the first response of intervention came from a study, a multi-center study. We now call it bundle of care, emotive bundle of care. Emotive is an acronym. And WHO again now formally adapted it in the latest guideline. Now, I want to pause at this stage to again emphasize what this bundle of care means. And even where we are limited, because we cannot, give all of this bundle, but we should strive. And that's because if we do this early, do this appropriate, early response, we're likely to save about 30% of lives. We're like of our pregnant women who have this complication, just this early response, we're not doing anything. And there are things that we should be able to do. If we do the costing, it don't cost anything. It's just for us to mobilize our will, organize ourselves strategically, look at what we're doing, and organize ourselves and ensure that they are there. Not only that, it will reduce the number of people that will require higher level of care, that will require those interventions that continue to challenge us, interventions that bring to, make us life talk as it were. We don't have the technology, we don't have enough blood, we do not have enough. When we do this properly, we're not likely to move to that state. We're even going to reduce the number of people that ultimately will be forced to, get hysterectomy. We have a number of young women, we know the issue of that, but a number of times we are forced to do that. So I'm pausing here to emphasize at this stage, to emphasize what this concept speaks to. Now, this concept speaks to the fact that having picked up very early a woman who is bleeding and is stable, we immediately, that's the E, we massage the uterus, confirm, like in about 70 to 80% of cases, that that there is atony. Like I said, atony is the leading cause. A number of times, when we just gently rub up contractions and all of that, we are able to establish that this is what is happening. And then a number of times we rub up contraction, we get the uterus to contract. All right? The O there is administration of an oxytocin. Okay? Now, depending again, this is contextual. First of all, the oxytocin of choice is oxytocin. For as long as it's been properly refrigerated between, the temperature that is between 3 to 8 degrees centigrade. When there's a problem in our environment, we know that we have issues with refrigeration, not just refrigeration, even where they are stored, bringing them in, transporting them. But the system that's organized, that is ready to confront the monster of postpartum hemorrhage, must know if the oxytocin they have in stock meets with that minimum requirement of being, of being stable, of being cold, and also without any doubt about its viability. Okay, otherwise, you have to look at another alternative. So that O there is, is a use of an oxytocin. Okay. Now, again, in other context where you do not have people who can give injections, okay, where we have lower health cadres, we don't have to use it. Okay, and that is where misoprostol comes in. And again, the nation at the national level, they've had to come up with a guideline that says, listen, you still have huge number of people deliver at home, particularly in areas that are, strife-ridden, conflict areas and all that, where even if they want to move, they can't move. Is that why they should die? That's not the reason. That's not the reason. It's not acceptable. And that is why we must even domesticate this policy that has just come from WHO. We must look at what suits us nationally, then of course subnationally. In other words, in the northern part, in the western part, in the eastern part, depending on the drivers there, we domesticate it. Even in Lagos State, we do know that we still have inequalities. We still have some local government areas that continue to give us, figures that still mirror what does happen in some of our zones that have very high figures due to look of that. So in other words, even Lagos State, even with our healthcare system that has been adjudged as the best 7th in Africa, not the whole country, Lagos State, 7th, we still have our challenges. You still have some local governments that have these problems. Okay, so we must domesticate and look at what does, apply to them. Okay, so that is the O. The thing there is the tranexamic acid. Tranexamic acid has now come in to, to help treat, not to prevent now, to treat, but to treat very early. You must, in the woman who is bleeding, stick to give tranexamic acid, within 3 hours. Okay, and how do you give it? Usually IV, you give very slowly. All of these things will be in the protocol, so I'm not going to give all of that, okay? But it's a game changer. And that is regardless of the cause, whether the problem is atony, whether it is laceration, whether it is tissues, return whatever, whether it's thrombin, you are encouraged to. There's evidence to show. Not only do you give early, you are even allowed to repeat within 30 minutes and again within 24 hours. So it must be available. It must be on the essential drug list because alongside other interventions in this emotive is come to radically, positively, and dramatically change the story. We must embrace it. The next thing, of course, is IV. Don't forget, like I said, that when they come in, some of those basic things that we must do, we put up a line. Where it is there, we put up fluids, crystalloids, normal saline, ringers. They don't cost anything. like I said, if you look at the cost of managing complications, you will know why there must be an investment in getting 1, 2, 3 normal size to keep the system, to keep the vasculation ongoing so that you do not have a shock, okay? And of course, the other thing is, having done all of this, you do a quick evaluation. This is not atonio. This is laceration and all that. Palm, that prepares you for the next stage, all right? This obviously is beyond me. This is ruptured uterus, this woman is bleeding and all of that. I am going to escalate to a higher level. I'm in a PHC, I don't have, or I'm even in a general hospital. Unfortunately, as we speak, I don't have an anesthetist because of circumstances. So I have to. And okay, so you now move to the next stage. Next stage, please. Okay, so the thing about all of these bundles, the summary is that instead of giving one after the other, you give one and wait if it will work. You give concurrently. Let me emphasize that, please. Previous slide, because of the importance, please. You give all of them concurrently. In other words, you are meant to give or implement all of these within 15 minutes of detection that this woman, don't forget that everything is prevention, early detection. We're not giving the best care early. Within 15 minutes. And the only way it can work is so in a system that is ready, where you can easily get your training. You can get normal salary. You're not telling the woman to bring money or the husband. Unfortunately, 70%, well over 70% of our women and their husbands still go through this out of pocket expenditure. For us to make progress, this must be consigned to the dustbin of history. Policymakers, everybody, advocates, you must mobilize the system, mobilize funds, redirect funds, and ensure that these simple things are done to save the lives of our. Enough is enough. We can't take it anymore. 15 minutes, we should be able to do this. Next slide, please. Next slide. Okay, so now, in all fairness, despite all that we do, despite this bundle of care, and again, in recognition of the fact that other people will come in a bit late. So we have what we call refractory postpartum hemorrhage. The concept of refractory postpartum hemorrhage speaks, to the category of women who have primary postpartum hemorrhage, who haven't gotten all of this early response. And I also have said that in other areas where you cannot give all of this as a bundle concurrently, yes, you give, even if it's one after the other, it's still better than not, but we should aim. But what I'm saying that even when you give all of this, you're still going to have women who will not respond. In fact, figures have about 10 to 20% of women will not respond even when you catch them. It just does happen. Okay? So we now have to move to the next level. And that is where you have the use of interventions. These interventions, again, could still be non-pharmacological. In other words, they don't have to be, they could be non-surgical. In fact, they shouldn't be surgical. Okay? It could be, usually they are non-pharmacological. You have given all the medications and all of that. And what is it that we need to do at this stage? So at this stage, before we go to the mechanical interventions before the surgery, we should be able to do some temporizing measures. That this woman is still bleeding and everybody is there, members of the team. We are alerting everybody. We are preparing. Are we referring? If we are referring, of course, we get the ambulance. Referral process must be proper. We want to ensure that the hospital that is going to accept the referral hospital is ready. It will be a disaster to move a patient who is bleeding to a hospital that is not ready, genuinely because they do not have bed space. So the referral process is itself a process that must be properly consummated to ensure that these people at this given time are ready to receive a woman who is bleeding. Okay? So while that process is going on, or when even in the given facility, you recognize that this case has not responded to this first line, and so you may need to escalate. You may need to take to the theater. What are those things that you can do while you are preparing either for referral of escalation to high level. We call them temporizing measures. They are very simple things. You can do what you call manual, pressure, uterine pressure. Okay, it's very uncomfortable to the patient. It could be very laborious. But what it does, of course, is to try to compress that uterus. And in fact, you can begin to have an idea of a uterus that will ultimately respond. It's worked in a number of instances. And even where it doesn't work, at least it reduces the number, it reduces the amount of blood that is lost. The other simple thing you can do is to externally compress, the external, the aorta. It's so difficult, it's so easy to locate, just above the fundus, a bit to the left. Just put some downward pressure. The aorta, of course, feeds all the vessels that go to, the pelvis and the perineum, including the uterus. So if you reduce the amount by just pressing, you don't pay for that. So, but we must know it's a temporizing, phenomenon. Of course, the other thing, which has again radically improved the fortunes of our women, is the use of non-pneumatic anti-shock garments. Every hospital, even at the PSC level, let alone the secondary healthcare facility level, must have this anti-shock garment. Anti-shock garment is one additional temporizing intervention that has saved more lives, that will continue to save lives. Okay? But again, using the garment is easy to do. The more people must be taught, you must learn, you must have job aids that shows how you give and what you do. And again, what it does again is to move blood from lower segment areas that could in quote be starved of blood, and such blood shunted to vital organs, the brain, the heart, and the kidneys. It keeps those vital organs going while we prepare to refer, or we prepare to escalate. Okay, it's very, very key. And of course, the other simple things, of course, include what we call the balloon tamponade. Okay, they are exotic tamponates, But like I said, we have our own tamponates, the police easily taught and it's easily put together. And what you need, your Foley's catheter and the condom, they're available. By the time you do drills, you can do all of this. But let me add that you are doing a balloon tamponade, you must have excluded other problems. You must be sure that there's no retained tissue. You must ensure that you have, sutured your lacerations and all that. Otherwise, you'll be akin to playing the ostrich. You try to tamponade where the problem is not, atonic. So the woman would have been assessed, and you are sure that those other treatable causes are not there. It's just that it's just fracturing. You do that. All of these temporizing measures help in maintaining the cardiovascular state and prevent a woman from moving from class 1 stage of hemorrhage to class 4. Okay? And ultimately improving the outcomes and putting the woman in the best possible shape to even benefit from other interventions. So the other interventions, I'll just quickly run through them. Of course, they are the use of the compression sutures, okay, and they are very key. They're easily taught, they're easily learned, especially in women who are stable and where we want to preserve their fertility. You've seen a primary gravidia who has just had a child. The woman will aspire to have, another baby. So it's incumbent upon us to try as much as possible. Why not endangering her life? It's very important. Okay? So we must contextualize it. We use some of these, fertility sparing interventions, including, like I said, these building sutures and all of that. Let me quickly recognize the great work done by Nigeria, ACK, in the eastern part of the country, that gave us our own type of, compressive tissue. It's easy to learn. All of these things, you have the videos. That is where drills, training, investment, come to play. You do all of these things, you save lives and all that. Now, Again, there are other, procedures, bilateral ligation of the uterine arteries. What you do is a function of the capacity of, among other things, of the surgeon, what you can do, what is appropriate, and all of that. I'm saying this again with respect to the next internal hernia ligation. If you can do it, fine, but you require skill set, a high level of skill set. There's no point doing what you cannot do, what you are not configured by way of skill set to do. All right. However, there are a number of things you can do. While we are doing this, we are assessing this woman. If this woman continues to remain unstable, please, if what you have to do, regardless of our parity, if what you have to do when she's still stable is to do a hysterectomy, please go ahead to do it. Okay? Usually, if you have to do hysterectomy, it must be a decision that has been well thought through. The consultant is around. There's a consensus that you need to do this to save the life of the woman, depending on what is causing. If you say, Tony, that is totally refractory to all the measures I need to save the man, you can't just do a subtotal hysterectomy. It's quicker. The woman, still has her ovaries, she has the cervix, she's stable. Occasionally, if you have a very bad placenta previa that has not responded, you may need to do a total hysterectomy. Whatever you have to do to save that woman's life, you have to do it. But if you follow what we've done, prevention, early detect, first response, ensuring that the system works, I tell you another, you're going to salvage more and more lives. And that's going to be our collective decision at the end of the day. Okay? Now, having, gotten done with the surgical intervention, we have saved life. There will be some complications. Okay? But like I said, let the woman be alive and let those complications be such that, they are not life-threatening. Some of them, of course, will include anemia. Okay? Anemia is very common. Okay, it's one very common short term that we usually encounter. Again, what has changed? If it's mild and all that, we can do iron formulation. If they can't tolerate, we can do, again, and I'm mentioning this, thanks to the work of Professor Afolabi and Galadanchi, the Avon trial that has shown clearly that in a number of people, rather than wait for blood or use blood injudiciously, blood that is not enough, we can give them parenteral iron, okay? Give them ferric, the brand of iron, carbomalase, that has been found to be very effective, okay, through the Avon trial. It's cheap, it's available. Yes, the problem of anaphylaxis is there, but we maintain, but more importantly, it works, it's cheap, it is appropriate here, and it helps us save blood, okay, for those who inevitably need it. In Lagos, for example, our population is about 26 million, and they tell us that we need about 260,000 pints. As strong as that department is, that unit, the Lagos State Blood Transfusion Unit, thanks to the wonderful job being done in that unit, and that is also being replicated in other areas, we struggle, to get enough blood for a number of reasons that are beyond the scope. So what that does mean is that even the blood that we have, you must judiciously utilize them. Again, driven by what? Best evidence. Where we can use oral tablet to do, don't transfuse. Where we can achieve the same effect using, parenteral iron, please let's give and ensure that we follow all the other things that go with it. All right. And I've talked about other things, other morbidities, one that commonly affects us if you don't act very quickly, of course, is the issue of kidney failure. You go to the dialysis center, you see victims, and it could be a lifelong, it could be very terrible. So that is why we must prevent. Okay, and of course, you have others who may come down with adult respiratory distress syndrome, ARDS, and all of that. We don't want that. Okay, now of course, issue of thrombolism. Other long-term complications will include Sheehan syndrome, infertility, uterine perforation, Asherman syndrome, and all of that. Our aim is to reduce the number of cases that die and the number of cases that get these life-threatening, complications. In conclusion, ladies and gentlemen, we recognize that PPH continues to be a leading cause of maternal mortality and morbidity globally and even in this country. They are preventable. Majority of these cases, mortalities are preventable by doing a number of these things that have been espoused in the last 15 minutes or so, is to get all the relevant people in the ecosystem, all the relevant stakeholders, the policymakers, with the health workers, showing compassion, and then of course, organization, be culturally sensitive, encouraging our women, driving demand, let them come, driving demand and all that. And our pregnant women, empowering them, educating them, ensuring that they're in a position to, and then all the barriers at all the levels, the barriers that drive, type 1 delay, the ones that drive type 2 delay, the health system problem, the government must invest. I didn't talk about, the health system generally. I alluded to it. The government has its own role. The issue of governance, the issue of regulation, the issue of, ensuring that we have enough hands. We must be creative. We must be able to tax shift. And, even when people jack back, what are we doing? We have long-term, short-term plans, like in Lagos and elsewhere. We must be able to tax shift, tax shifting and tax sharing. Use people, at a lower grade are trained to achieve the same thing. In other areas where they don't have gynecologists, where they don't have doctors, make use of CHOOS who are trained, okay, who are motivated to do some of these things. In some of our people who, because of conflicts, can't even come to the, they want to come, they can't even get to the PNC because of strike. Why the government is trying to deal with the problem of strike? Why don't you use lay health workers, people in the community? Let them get misoprostol, like it's been expounded and being pushed at the national level. Okay, let us get there. How many people come to deliver hospital and come to deliver in the hospital? Yes, we are working on it. How many people come? So let's take the back to them. Why we continue to work on the drivers that prevent them from coming to us? They shouldn't die. We have evidence that people who deliver at home, baby is out. Give them, misoprostol. We are aware of problem of abuse and all of that, but we can still monitor. Let's look at the gains. Let's look at the lives we save. If it's okay, some of them could use as an abortifacient. What of those who do not use it? We can monitor and deal with this. So those who deliver, so they shouldn't die because they are delivering due to no cause of that. Evidence has shown that if we give them misoprostol, 2, let them take it orally and all that. It will help reduce a number of these cases that would, again, go on to cause problems. Okay, so again, in summary, like I said, prevention, early diagnosis remain key. We must ramp up the capacity to provide obstetric care. And it's something like this, we have CMONC and all that. Just organize the system. Ensure that you have the CMONC care that takes care of a concentric number of, hospitals who are ready, equipped. Ensure a good referral system. In summary, I think we can do it. I think we know what to do. We just need to agree that our women should not die. All right. The issue of women's health is a human rights issue. We must all work together and agree that we have to change things. What WHO did, in my opinion, on the 5th of October, that's on 4 days ago for me, is just a master stroke. It's now left for all of us, national level, ministry, policymakers at all levels, to latch onto that and agree on this day, having listened to us, that enough is enough, we should do better. Thank you very much. Next slide. Thank you for listening. Thank you so much. There's so much more to say.
Thank you so much, Dr. Imosemi. Thank you so much for that lovely and erudite lecture that you just gave to us. You did justice. We actually did not expect anything less. Thank you, sir. We truly appreciate you. Thank you.
Thank you. It's my pleasure. It's my pleasure. I'm sure the case presentation and question and answer session will provide an opportunity, to perhaps look at some of the perspectives, Thank you, MDoc. All right.
Thank you so much, sir. We'll be taking the case presentation right now. Can we see the clap for Dr. Imosime in the comments, in the reactions? We truly, truly appreciate you, sir. That was a wonderful session. So much learning, so much insight. We truly appreciate you. Dr. George, are you ready?
Good afternoon, everyone. Good evening, everyone. Thank you so much, sir, for such a lovely session. So for everyone listening, we would now be taking the case presentation. This is a case study from Specialist Hospital Ekiti. So the patient is AA, 36-year-old, gravida 3 para 2 non-booked. She's being referred from a comprehensive health center. She was referred on account of a labor case with eclampsia, admitted on the 21st of September 2025 at 10:30 a.m. Next slide. She was planned for emergency CS. Outcome, she was delivered of a live male fetus via SVD in the theater via SVD. Okay, I think there's a typo error. She was delivered of a live unit in the theater at 2:16 p.m. Bed weight was 4.65 kg. She had postpartum hemorrhage secondary to second-degree vaginal and perineal tear. Both mother and baby remained stable and well. The nursing management is consisted of checking her vitals, massaging the uterus to ensure contraction, estimation and recording of blood loss, observing for any signs of shock or pallor, administering of oxytocin, inspection of the perineum for any lacerations and repair of such lacerations, administering of other prescribed medication. She was monitored closely and was reassured. Medical management consisted of a PCV check, blood transfusion, and oxygen administration. Postpartum course was as follows. The mother and baby were discharged on postpartum day 4. Postnatal clinic appointment scheduled at 4 weeks. Both mother and baby remained stable and well. Okay, sir. So they've specialists have presented a case. We would love you to offer your expertise and your insights and any other recommendations you could have for them. Please, thank you, sir. As you go ahead, sir.
Okay, so thank you very much. So this was, for me, a very close shave for the mother and baby. A very close shave, especially given the outcome. So again, thank God. So the summary essentially was that we're dealing with a para 1, I think gravida 2 woman who had been in labor and the labor probably, had been adjudged prolonged, and they now decide, and then she had fitted, so you had eclampsia. So and then at the end of the day, because of the fit, and perhaps because of the fact that labor was prolonged, they now have to refer, to a center where naturally they prepared, they stabilized, and they were going to do a cesarean section. I think on the operating table, the woman pushed and delivered a 4.65 kg, baby. That is a macrosomic baby, So again, understandably, the woman thought, because one risk factor for A21 and of course perinatal is to deliver a big baby, a baby that is bigger than 4 kilograms. In fact, the woman must have a very to have delivered 4.65 kg without any sequelae. I mean, that's a baby they get that should have had, that was at risk of having, shoulder dystocia and all manners of, this one, we don't know again the obstetric history of the first baby, the past obstetric history. Had that woman did she have a big baby? Is she prone to having big baby for a number of issues and all of that? Okay. Now, in that index pregnancy, we now thank God that the woman went to the comprehensive healthcare center for antenatal care. And that's why the emphasis right now, for that woman who has made herself available, we must provide quality. Quality of care, even if she didn't have any antecedent risk factor, there's no way in this pregnancy that we would have noticed a large folded uterus. A large folded uterus will tell you that there's something happening. That baby is big. And you just to use your tape rule, that baby is bigger than the date. Okay? Don't forget, like I said, the thing is prevent, early detect. Okay? So they would have noticed that this baby was bigger than date. They would have done a scan early, and later they would have confirmed that it was not a twin, but it was a big baby. Why is this woman having a big baby? Is she issue of blood pressure? Is it issue of diabetes? Is it issue of dietary indiscretion? Is it genetic and all of that? But baby is big. Okay? It's for them at the lower end that will say, okay, this big baby, is this the right place to have this baby? Supposing that woman had gone ahead to deliver baby at the referring hospital, and supposing the tear, the laceration was even worse. Those are cases that will have second degree, third degree, fourth degree, and all manners of terrible things. They can even have what they call uterine rupture. Okay? So, there were early warning signals, but thank God that they referred. They referred, the woman ruptured, but she had fitted. And that is the thing about eclampsia. Hemorrhage usually within 2 hours. Postpartum, they can die if you don't do the right thing. Eclampsia, I know that will give you some few more days. But you could see that eventually, when they were preparing to do cesarean, which was fine, again, depending on what they found during vaginal examination, because the woman had a child before, she was able to push. But the pelvis must be capacious, to have been able to push out 4.65 kg with the only sequelae being, a second degree tear and all of that, okay? But these are things that we have recognized. So by the time such a baby is coming, and nobody needs to tell us what areas to look out for. Atony, yes. Of course, the issue of big baby, yes. Laceration, yes. So you quickly. But before you get to that, they did the right thing. They were ready for even cesarean section. That means the woman was on IV line. They had all the other things. So we thank God that the woman survived. But the tendency, if care is not taken, is for the woman to even have a much bigger baby in the subsequent delivery. in subsequent pregnancy. So this is a woman that has to be counseled. We have to try to know why she's having big babies. I would suggest that that woman should be registered in a place in subsequent pregnancy where she doesn't have to be transferred. Of course, I know a number of times logistically may not be easy, but you must plan it. They must be ready logistically. Because the tendency, if there's no diabetes in this pregnancy that was not detected, the tendency is for babies, to subsequently get bigger, with next level of pregnancies and all of that. Okay, so a lot of things happened by referral was done at the right time. 4.65K baby in a center where they could do cesarean section. They were able to take care of the tear. The tear wasn't. It could have been worse. Like I said, she could have ruptured. And once you have rupture, especially with an extrusion of the baby into the abdominal cavity, or when you have involvement of the uterine artery, in 2 hours the woman is dead. So let's thank God they did the right thing, they repaired and all that. So let me stop at this stage. Thank you.
Thank you very much, sir. Thank you so much. So we have a couple of questions in the chat, but we just want to give them for one person. Please raise your hand. But while we are waiting for that, we have a couple of questions in the chat. So we'll just be taking it two at a time. Someone asked that, at what gestational age can a pregnant woman deworm? And also, another person is asking, how do we effectively empower our PHC to play a vital role in quick detection of high-risk patients with PPH, especially clinically, to determine the appropriate time for effective referral to a higher level of care? So, sir, we just want you to quickly, give responses to these questions.
Okay. Okay, so the issue of the deworming, usually, most of the drugs most of the anti-helminthics are not teratogenic. So, but for all this what you can do that, maybe from while pregnant, depending on what you are using, or with safety from the second trimester. All right. So that is that. Now the PACs must be strengthened, to do what they have to do because they are closest to the people. And that's why at the government level, there's a plan to ensure that, more, comprehensive health centers are upgraded and made more functional. And let's exclude the ones that are affected by strife and all of that, okay? So we must. But having said that, depending on what you have, in Lagos, for example, our PSCs, we have doctors, we have who are experienced, referral system is stronger, but elsewhere, you have people who have been trained, you have nursing sisters. So there must be domestication. Each PSC, of course, with of course, intervention or input from the higher level at the PSC, at the state level, must agree on what they do. Otherwise, PSCs are meant to take low-risk pregnancies. Pregnancies, no previous cesarean section, no this. But we've agreed also that even a pregnancy that has been adjudged as being low risk, especially when it comes to hemorrhage, could bleed. And that's where the issue of protocol will come in. And that is where we must expand the use of calibrated drips everywhere now, even at PSCs. It should be available. People should invest. Government should invest so that you get this thing very early and decide that, this woman is bleeding. No, I can't do more than this. I need to refer. So the use of calibrated drips. Meanwhile, even while doing that, you can roll out some of the basic, bundles of, any response, like I said. Okay, depending on, if you cannot do it as a bundle, you know what oxytocin to give. You know that you must set a line. If you cannot do that, and this PSC should be able to do that, okay? So you roll out this. So to answer your question, each PSC, depending on the circumstances, on the context, should be able to do what is meant to do. What is meant to do is, so because they're closest to the people, there's going to be a protocol. that would, be okay for them. This is what they should do. If there's any problem, stabilize, and they'll let them know. Simple things that they'll be able to do. All right, and then refer. Okay, those PSC, the issue of transport, like I said, we have an organized system. That's what MPDSR does. You look at some of those PSCs or some of those hospitals in the rural area. Type 1, type 2, type 3, type 1, type 2 delays. You can deal with them and then you move them to an appropriate center. Okay, so look at the use of protocols and then training people to do what they are meant to do. And what we've agreed at the stage is that the protocol that we're using in the general hospital may not be apt for our PSC. So we must again domesticate. We must tinker with it, recognizing the capacity. And now the capacity of one local government may differ from the other one. That some of our regions are still are not as blessed as the others. So, however, we must invest, we must innovate. We know what to do. Thank you.
Yes, sir. We also have like 2 more questions that we can take. It says, where can we get anti-shock garments so the private practice can be at alert to prevent maternal mortality rates? A lot of practical demonstrations seen, but the NASG not available.
Okay, so the NASG is available. And one, you see, what drives supply? Another is where there's demand. Let me tell you, some 5-6 years ago, I remember when we went to Brazil. Yes, FIGO 2018 or thereabout. That was when there was ample and incontrovertible evidence of the importance and usefulness of anti-shock garments particularly in low resource environment, like Nigeria and all of that. As soon as we came back, Sogon, took up the gauntlet and rammed it up. And I remember then the Commissioner of Health, especially accessing information about the usefulness of this intervention. Maybe initially, before we know it, people learn that there will be a need for it. And if you go to the motor market, if you go to the relevant shop, if you go to, outfits that are into the vending of health commodities and all that, you'll find it's available. It's available. And you know what? From your YouTube, you can learn. So not only is it available, you can learn how to use, how to apply it, how to remove it. It's been available for a long while, but the use gained traction when there was evidence after use and all of that, that this was saving lives and preventing deterioration, from mild to severe, hemorrhage, and then of course, positively impacting alcohol. So it's available out there. And because people now know that there's a demand for it, people are getting it, and it's become cheaper and cheaper over time. For the stomach centers, and even for PACs, we must canvass that the state, the local government must make it available. And we must be taught. Private hospitals, in fact, when they are doing the check, if you do not have it and all that, they should make it compulsory for you to have it, before the next visit. Otherwise, they should not, you should not be allowed to price of them, because it's one thing that you learn that can save life, prevent vital organs and save the state and individuals for spending more money on, complications that won't even bode well. So it's available to answer your question. And it's not being proven by supply demand, equilibrium.
All right, sir. We have 2 very interesting questions. Someone says, in areas where measuring drips are not available, can parts be used to estimate blood loss? And if yes, how can it be used? And then we also someone also asked, considering that early response alone saves 30%, should facilities be doing emergency drills for situations of PPH just as a way to stay prepared?
Okay, so like I said, starting from the last question, is the way to go. It's the way to go. Countries that have done well, states that are doing well, are states or are institutions that place premium and make investment. See, overseas and all that, the leading cause is not hemorrhage of their maternal mortality, it's embolism and cardiac problems. You understand? They can do, I didn't mention uterine artery embolism and all that. They do all of these things. If they want 100 pints of blood, they don't even give blood, it's products. They have it. But that is why, I'm not too happy to say that's why they are high level, but we can. So, but we have, low cost, highly effective, evidence-based intervention, simple things like anti-shock garment. Let's get how much is it? Invest. Let's train people. There are teachers everywhere. Let's teach people, not just train, retrain. Then when people are trained, let them step it down. Let them train the other one. So that's the way to go. It must be an integral part of it. So that when we are taking performance and all that, and people be trained. In Lagos, the Health Service Commission is one of those things. And even the government at the highest level, Ministry of Health, ensure that they have training for CHUs, for JHUs, for doctors, for consultants and all that. It is the way to go. And in some of these areas where training, sepsis could take 1 week of death if there's no intervention. Postpartum hemorrhage is 2 hours. Antepartum hemorrhage is 8 hours. Uterine rupture, 12 hours. Eclampsia, 3 days. So that hemorrhage, there must be training. Please, we must begin to sing the song after this, please. Okay, and then with regards to the question about drip, see, the thing is, any other method of estimation and all that, okay, is prone to, error. Yes, those drips and all of that, yes, there are standards. What is standard? If each pack, each swab is sold, is about 30 mils. If this one is, again, how do you, okay, so that is why we must embrace the right practice. Let's get drips. Let it be driven by calibrated, not just drip. Let it be driven. And that's what it is, okay, fine. Even if we don't have drip, measure, the vital signs. We're not talking about shock index. Okay? We don't even want the woman to wait to be in shock. But once the blood pressure, the pulse rate, or the systolic pressure is going down, we can easily measure that, and the pulse is going up from 90 to 100, know that something is happening. Okay? So, to answer your questions, yes, there are so many other things. In fact, there wasn't any room for that. People have used artificial intelligence and all that, but I'm looking at what is appropriate, what we can easily use.
Thank you, sir.
Healthcare is not cheap anywhere. There must be investment at all levels. And if we organize ourselves, the NGOs that who are rich who will do this, just decentralize it. We can get people, they will, your local government, they will give you all the drips that you need, all the calibrated, not all the calibrated drips, so that you can unequivocally measure. Okay? So that is the way to go. Any other thing is subjective and not sustainable. All right.
Thank you so much, sir. Please, let's appreciate Dr. Imosemi in the chat. Let's appreciate him through our, through our reactions. We truly, truly appreciate you, sir. Thank you so much, sir. So quickly, we'll be moving into the other aspects of the session. We want to remind our doctors in the house that we offer continuous professional development at MDoc Healthcare in partnership with Sub-Saharan Health Solutions Nigeria Limited. We are offering continuous professional development for doctors in Nigeria attending our tele-education sessions. Terms and conditions apply. But to benefit from this, please email mqn@mymdoc.com. It will also be put in the chat so you can pick it up from there. Please remember that the slides will be shared. Definitely, the slides will be shared to all participants of this session. Again, we're encouraging you. The complete health link will be in the comment section in the chat. Please check out Complete Health, visit our website, visit our app, download our app on your phone, and also our Navi Health. Navi Health link will be put in the chat box. Thank you so much. Please don't forget to follow us on all our social media platforms. We are on Facebook as My MDoc. We are on Instagram at My MDoc. We are also on X, formerly Twitter, at MDoc. We are on YouTube as well, and we are also on LinkedIn. Please follow us on our social media platforms so you can stay up to date on our sessions and even the work that MDoc is doing. Thank you very much. Thank you so much, everyone, for joining. We truly, truly appreciate you. See you on our next tele-education session. Thank you.